I'm so happy to be here and sharing what we have learned about using the MRI in day-to-day practice for prostate cancer. The talk is primarily directed towards the benefit of residents and practicing urologists. The topic was to make the reading of the MRI a little bit simpler. I can tell you it is simple, it is not that complex. The only thing is that we do not have a habit of seeing the MRI ourselves, just like we did use CT scan in day-to-day practice. And that's what makes it some people to believe that reading MRI is a little bit difficult. We don't have to know a lot about the MRI. We just have to know what is important while we are practicing the utility of MRI in day-to-day urology practice. So what I'm going to do is that I will stick to some of the basic aspects which all of the residents and practicing urologists should remember while ordering the MRI, while reading the MRI. It's a vast topic, so I will not be concentrating the knowledge in a small 20 minutes. So whatever we can cover in these 20 minutes, we'll do that. And maybe later on, we can have another session to discuss if we want to discuss any particular aspect in more detail. So what I'm going to do is I'm going to clarify certain thoughts about what is multiparametric MRI, what sequence we should be ordering when we are ordering, what machine. Basically, there is a lot of confusion about whether we can do it on 1.5 Tesla or not. Very important aspect is when we are ordering whether it's important for us to order always a contrast MRI or non-contrast MRI will do. Then I will switch over to reading the normal MRI, because how do we start in reading a new technique is first we should know the normal. Once we can make out that it is not looking normal, then we start explaining the abnormal aspects on the MRI film. And then if time permits, we will be discussing different case scenarios where we will be discussing actual case scenarios where patients have been followed up and the MRI made a difference in humanity. How we move the next slide?
Yeah, we can see the.
Yeah. So where are we using MRI in day-to-day clinic practice? So everyone knows that we are using it for evaluation of raised PSA, especially when there is a non-palpable disease, whether we should do a biopsy or we should just keep them on follow-up. We are using now targeting the biopsies using either a cognitive MRI guided or fusion biopsies nowadays. More and more usage of this MRI is being done in non-invasive surveillance, especially for low-risk cancers. And this way we can probably decrease the number of follow-up biopsies as well. None of the patient wants repeated biopsies while they are on surveillance, and that is one thing which sometimes keeps a patient away from surveillance also. So MRI can help us in that. Of course, we have been using it for staging of prostate cancer. Those people who are doing radical prostatectomy on day-to-day basis, they know the importance of MRI nowadays and surgical planning, choosing the appropriate case for surgery, planning nerve sparing, whether on one side or both sides, how close they can go to the prostate to do a better nerve sparing, whether to do bladder neck preservation or not. All these things can be decided based upon plain simple MRI, and it helps a lot. Even in US, where MRI was not being covered by insurance, many surgeons want to do MRI even if the patient has to pay from their pocket, because it makes a big difference in the surgical planning. Having said that, everyone recognizes the value of the MRI in practice, but there are many things which are still lacking. What is still lacking is the consensus about the definition of clinically significant prostate cancer, not only on the biopsy, but also what would be a clinically significant prostate cancer if we want to use MRI for deciding about that. There is hardly any consensus about the best combination of parameters for conducting MRI. So nowadays you will see that although recommendation is multiparametric MRI, but biparametric MRI, which is basically meaning thereby you do a T2 weighted image along with a diffusion weighted scan. Both of these are non-contrast MRI, and many studies have shown, and also we also feel that biparametric MRI serves the purpose in majority of the circumstances. And I will come to that, where you can just order a non-contrast MRI and it will serve the same purpose as a contrast MRI. All the advantages of decreasing the scan time, thereby making it comfortable for the patient, making it more cost-effective, avoiding all the potential side effects of contrast in some of the patients. Then what we need to improve is the issue of inter-individual variability reporting. Although pilot scoring system has made a big difference in the way reporting is being done, but still you will see that we are still not very objective in the way we report. So we are still using the word like mild, moderate, severe, the low risk, high risk. So these are more subjective terms. There is no objectivity into it. But I'm sure in future things will come where we will be more objective. So these are some of the things which we still want in MRI practice, but this is how science works. We have come a long way in the way we are reading and using MRI, but still a long more way to go. Of course, we need to improve gadgets. We started with less than 1.5 Tesla. We started using 1.5 Tesla with, and subsequently endorectal coil. Now, majority of these cities have 3 Tesla machines, at least one or maybe more than one. Machines are having greater spatial resolution, image clarity, but still it needs further improvement. As we have seen, the way ultrasound has improved in the clarity, I'm sure the MRI is also something which we need in terms of better MRI imaging. Now, coming to what is multiparametric MRI? I mean, this word is so commonly used nowadays, and many people are just using multiparametric MRI because we see so many prescriptions coming from other cities where they have written multiparametric MRI, but I'm not sure whether everyone understands while ordering whether they really need contrast MRI or no contrast MRI and multiparametric MRI in all cases or not. So in simple terms, multiparametric MRI is defined as an image acquired with at least one more sequence in addition to the anatomical T2-weighted image. So when we were ordering MRI pelvis in past, T1 and T2 weighted images, which are basically anatomical, which gives anatomical information, were the sequence used. And then subsequently, some of the functional MRI or functional physiological MRI images like diffusion weighted images or dynamic contrast enhanced images also, and then MR spectroscopy came into picture. So if we order anything which includes T2 weighted image, that is the primary sequence, along with any of these diffusion weighted or dynamic contrast enhanced image or a spectroscopy, all these will qualify as a multiparametric MRI. So multiparametric MRI in day-to-day practice nowadays with the pilot scoring system basically means we are ordering a T2 weighted image with a diffusion with or without a dynamic contrast enhanced image. So this is what is the things which are marked in red are part of the multiparametric MRI in the current pilot version 2.1, where T2 weighted image, diffusion weighted image, and dynamic contrast images are being ordered. Magnetic resonance spectroscopic imaging is no longer considered that important, and this is not part of the day-to-day multiparametric MRI in clinical practice. It may still be used in university setting or research care settings, but in day-to-day practice, MRS is no longer being ordered. It should not be ordered because it makes it much more costlier. Not every center will have it, and more important is that it is not contributing much to the diagnostic capability. Now, coming to what is coming up nowadays is bioparametric MRI, basically meaning thereby only 2 parameters, a T2 weighted image along with a diffusion weighted image. Now, these 2 parameters can easily be done without using a contrast. So this is basically a non-contrast MRI, and the benefit is that without wasting much money, you are getting all the necessary information in majority of the patients. I'm using the word majority. I will be telling you.
Rajiv sir,
Ajit.
sorry to interrupt. Is it possible to switch off the fan behind you? There is some disturbance in sound because of that.
Sure, I will.
Thank you.
So biparametric MRI can provide you information in majority of the circumstances, and I will tell you specifically how to order a contrast or a non-contrast MRI. Now, regarding whether 1.5 Tesla is good enough or 3 Tesla, why is it important? Because 3 Tesla machines may be available in most of the cities, big cities, But majority of the MRI centers will still be using a 1.5 Tesla machine, because 1.5 Tesla machine is good enough for all the brain and spine related imaging. And majority of the bulk of the business to these diagnostic center comes from brain and spine imaging also. So it doesn't make sense for them to invest in a 3 Tesla machine if the volume of prostate cancer imaging is not much. So that is why it is important for us, for people who are practicing in other towns and smaller cities, about to understand whether 1.5 Tesla is good enough or not. What is more important is that we have to understand that we cannot go below 1.5 Tesla. 1.5 Tesla is the bare minimum which should be used. Older 1.5 Tesla machines are also known to use. So what are equivalent with the current understanding is that a 3 Tesla machine or the contemporary 1.5 Tesla machine scanners are good enough for good imaging quality of an MRI. Regarding the endorectal coil, again, a newer version of 1.5 Tesla machine and also 3 Tesla machine can give a good images without use of the endorectal coil. Now, why not use an endorectal coil? If given a choice, putting in an endorectal coil always improves the signal, so increasing the quality of the image. But using an endorectal coil makes it difficult for people who are using it because of various reasons. One, it adds to the cost and it adds to the discomfort to the patient. And also, when we are using an endorectal coil, we are using either a balloon around it with air or some sort of a liquid, perfluorocarbon or something. It also can distort the image. If, say, for example, we use air, it can distort the image. Investing in an endorectal coil, which primarily will be used for prostate, doesn't make sense for any center if they are not using many prostatic scans. So that is why it is almost phased out, especially when there is a 3 Tesla machine available, you certainly don't need it. And with the newer 1.5 Tesla machine, you anyway don't need an endorectal coil in most of the circumstances. Now, even with 3 Tesla machine, not every scan or the scan quality is same. Now, I've seen so many scans coming from, say, Bangladesh, Dhaka, Bangladesh, and from, say, Chandigarh and other towns in Delhi, other smaller centers in Delhi, where the quality of image is so good that it is much better than some of the bigger hospitals in Delhi or maybe some of the university centers in Delhi. Now, what is the difference? Both of them are using a 3 Tesla machine. The difference is probably in some of the centers, they don't bother to optimize the imaging protocol. And that makes a big difference even when they are using a 3 Tesla machine. Maybe the radiologists are not complaining, but it is for us urologists, when they start seeing the images themselves, they will realize that even with the 3 Tesla machine, some of the images are really bad and you can't even make good. So you need to demand quality image from your radiologists. Sit with them and tell them that, if you have some good image, show them that why don't you reproduce similar kind of image? You have a good machine. So it's just a matter of optimization of the software and imaging protocol. So till now, what we have learned, a 3 Tesla MRI is recommended, but not always necessary. Here, I would like to tell to my residents and practicing urologists that if you do not have a 3 Tesla machine, order for a 1.5 Tesla MRI. But do not go for a CT scan. CT scan serves no purpose. For staging and local staging of prostate cancer, the image doesn't add much other than probably the lymph node. Or if there is extensive disease, of course, CT scan will show it. But there, you don't need it. So if you are ordering for imaging in when you are evaluating a localized or locally advanced prostate cancer, ask for an MRI. Even a non-contrast MRI is much better than the best quality of CT scan when you are evaluating the prostate. Similarly, there is a very common habit of asking for a PET scan. Please do not order a PET scan for localized prostate cancer. Maybe it can help you in extensive metastasis, maybe an FDG PET may help. But I understand PSMA PET is not available, but do not order for a conventional FDG PET when you are investigating a prostate cancer. So endorectal coil is not necessary with 3 Tesla. It can improve the signal noise ratio in 1.5 Tesla MRI, but with a newer 1.5 Tesla machine, the image quality is as good. Now coming to the important aspect of do we have to order a contrast MRI in all the patients, or unknown contrast MRI will do? So in what clinical scenario contrast MRI is necessary? This I would like to answer in subsequent slides. Or in what situation unknown contrast MRI will sufficiently serve the purpose? Now, before we move on to that, we need to understand where at all the contrast MRI or dynamic contrast enhanced imaging is helping. Um, Certainly, using a contrast does not contribute when the finding on MRI is period 1 or 2. So in period 1 or 2, basically the prostate seems almost normal. It, it is so normal looking that there is no suspicion of tumor. So obviously contrast has not helped much. Now, similarly, in situation where is a very high likelihood of clinically significant cancer, that is period 4 or 5. Period 5 is basically where the cancer is so glaring, is so staring at your face that either there is extensive extracapsular extension, extensive seminal vesicle invasion, or big lymph nodes. It's a period 5, no doubt in anybody's mind. So what's the point of giving contrast in these patients? No. Similarly, period 4, majority of the period 4 which a radiologist will label, they will be labeling it in circumstances where they're pretty confident that there is a cancer. Otherwise, they don't place their bet on period 4. What they will label is period 3. So essentially, out of the 5 period criteria, period 1 and 2, period 4 and 5, this is dynamic contrast enhanced does not contribute. Where it is contributing? Only in certain set of period 3 lesions in the peripheral zone. I will tell you exactly in what situation. So this is the table which is used for period scoring system. For peripheral zone, the predominant sequence which decides about the period score is diffusion weighted image. And for transitional zone, the primary sequence will decide about the primary sequence means you basically base your decision majority on the primary sequence, and then subsequent sequence may help in further clarifying. So say let's come to peripheral zone where 70% of the tumors arise. So in period, if the diffusion weighted image shows a 1 and 2 kind of image, it doesn't matter what is looking on a T2 weighted image or a dynamic contrast. So no contribution for DC. Similarly, in 4 and 5, if it looks 4 and 5 on a diffusion weighted image in peripheral zone, it doesn't make a difference whether what is the kind of image which is seen on dynamic contrast analysis. So only in period 3, seen on the diffusion weighted image, it can make a difference. If DC is negative, meaning if it shows no early enhancement, it may be labeled as period 3. If it shows some early contrast enhancement, focal contrast enhancement, it may be labeled as 4. Is it really going to make a difference in clinical practice? Now, most of you might know that even with period 3, if the clinical suspicion is high, we are anyway going to do a biopsy. So how does it matter whether radiologist has labeled it as 3, 4 instead of 3? We are anyway going to do a biopsy. So it has made no difference. Now coming to transitional zone. Primary sequence is T2 weighted image, and secondary sequence which helps is a diffusion weighted image. DC doesn't matter. Whatever it is, it doesn't make a difference. Now the only argument which is given by radiologists and also the paper on pilot is that what if the diffusion weighted sequence is not adequate? Not adequate means the quality of diffusion weighted sequence is not good. So this can happen. The MRI, when you start looking at the MRI images, there is no doubt that majority of the centers will give a good T1 and T2 weighted image. Now what is lacking is the quality of imaging in diffusion weighted image. The contrast and the clarity of diffusion weighted image is not yet good in most of the machines. Why? It's basically a software related issue, the machine gadget related issue, and there's a lot more to be done. But whatever we have right now, it can still be affected by, say, maybe patient is moving a little bit. If there is a lot of time taken during the MRI, patient gets restless, and then of course the movement starts. And if there's a lot of air in the rectum, or say for example, if there is an implant in the hip, then the quality of diffusion weighted image may not be good. So only in those circumstances, diffusion weighted image helps a little bit. You see here, it means that diffusion weighted image could not be interpreted well. So there, the sequence of contrast enhanced may help a little bit to the radiologist. Now, these are very limited circumstances. So what should be done? That ideally, the radiologist, obviously the radiologist will be there to monitor. So what they should be doing is they should be doing a non-contrast image in all the patients. And only feel that contrast will be needed. They can always decide to do contrast at the point of time. So does dynamic contrast enhanced image contribute in most of the large peripheral tumors? So if the disease is palpable, if the DRE clearly shows that there's an abnormal DRE or there's a big tumor, a hard, one of the lobe of the prostate, maybe both of the lobe of the prostate, it really doesn't contribute. Why we should unnecessarily spend money as well as extra time during the imaging, and also maybe get an unnecessary RFT done and patient need to go fasting. A non-contrast MRI not only takes shorter time, but it is easier to schedule the MRI. It takes less time. You know, when we are ordering an MRI, a multiparametric MRI, without a specific instruction to the radiologist, they have to keep double the time of the MRI scanner compared to when they do a spine or maybe a brain. It takes at least double the time, and maybe sometime more, because it takes so much of time in doing all the sequences. So if we can shorten the sequence time, it not only is comfortable for the patient, because most of the patients who undergo MRI, they will discuss about being claustrophobic. So more the time they spend in that tunnel, more they are scared. So imagine if you want to repeat the MRI again and again, say patient on surveillance. So their first experience will decide whether they will go for a second MRI or not. So try to shorten this MRI. So it's not only shortening the duration of the MRI, but also spending less money. So most of the lesions, if they are palpable and where biopsy is indicated, you don't need any contrast MRI. Majority of the pyrethroid lesion on diffusion weighted image will still be considered for biopsy. So what's the point in giving contrast in these patients? So what we have learned till now, clearly abnormal DRE, meaning a large peripheral zone tumor, non-contrast MRI is sufficient. Now, in situation where you are evaluating a serial rise in PSA, but a normal DRE, we may use contrast. It is radiologist discretion. Why? We may use contrast because if there is an anterior big tumor which is clearly visible on a T2 weighted image, still no contrast is needed. But in case there is no clearly visible tumor on a plain MRI, then you may use the contrast, and the radiologist at that time may be able to decide. Similarly, equivocal DRE, we may use contrast. Uh, for characterization of lesion is one of the theoretical reasons we may use contrast. Otherwise, we are anyway using bone scan or PSA and PET scan. So, take home message is, if there is an abnormal DRE, no need for contrast MRI. And similarly for metastatic disease, large tumors, no contrast. So that brings down a very small segment of the patients where contrast will be required. So this is the reason why MRS is no longer considered. You see the accuracy, if you use just a T2 weighted image, 70% accuracy. Area under curve of 0.91 if you use these three sequences. So if you add DWIT to T2, then accuracy improves to 86%. With dynamic contrast enhanced image, stays almost the same, but still may be useful in some circumstances. If you use MRS, no contribution at all. So the cost, because of extra cost, because of the MRS, the availability issues, because MR spectroscopy need a separate software as well. And more important issue is reproducibility of MRS. The MRS in one center may not be as good as MRS in other centers. So because of all these issues and with hardly any contribution, MR spectroscopy is no longer part of the PIRAD. I would urge the practicing urologists to specifically do not write MRS. It is still very commonly being used. Maybe there are other pressures. I'm not sure about it. But if you believe that MRS is really helping, I'm telling you it doesn't really make a difference. Another point which I want to bring to the focus here is that, when you get an MRI report and image, you will see there are 6 or 7 separate plates in that folder. Now, all these plates cost money. In this era where we want to decrease the cost, every plate costs money. And what do you find in those plates? Useless films. What are those films? These are part of the MR spectroscopy. Those films, whatever section and films will be there on those films is decided by a technician, not even by a radiologist. The technician is sitting there in the evening and decide and print out those plates. I found that only one or two plates are useful. Rest of the five, six plates are useless. We have wasted a lot of money and resources on them. We are contributing to the pollution on Earth with all this. What is can be done is ask your radiologist what you will need. You need maybe a T1 axial, a T2 axial, a sagittal and coronal image, and maybe a diffusion. The rest of the information can be given to you on a CD. CD costs maybe 7-10 rupees. But these films cost a lot of money. It is difficult to carry around, doesn't add anything, and we are wasting money. So tell your radiologists and centers we don't need this. Now, as I was telling you that when we are trying to read an MRI, where do we start? We start with something normal. If we know what this is normal, then we can try to explain what is abnormal. And this is how we start taking baby steps in learning. So for the point of view of learning, I've just put in here a few of the slides which shows a normal T2 weighted prostate. Now, I will tell you what are the normal structures here. This is an axial scan, a T2 weighted scan. The reason why I'm saying T2 weighted, I will show you in subsequent things, but it is very easy to identify out of those 5-7 films what is a T2 weighted image. A T2 weighted image will always show anything which contains water as bright. So if you see in subsequent cuts or any other cut where the bladder is seen, and all of us can identify the bladder. So bladder will be looking white because of the urine content in it. So anything which looks white or bright is on a T2 weighted image it will be telltale sign that this is like you see the synovial fluid in the hip joint because it is liquid. It contains water, so that is why it's looking bright like here and here. Similarly, the high water content in the peripheral zone. This is the peripheral zone. It is looking bright. So this is the normal peripheral zone. Mustache-like, symmetrical on both the side, bright looking. And this is the BPH, because this patient may have BPH, this is the hypertrophic transition zone, the BPH component is there. Now, around the BPH, there will be what we call a pseudocapsule. Why it happens? Because of the compression of the tissue. So anything which is compressed, it has high fibrous content and less of water. So it is looking like a dark area because of the lack of water. So this is the pseudocapsule around the BPH enlargement of the prostate. So when we were doing, say, BPH surgery, the open prostatectomy, what we used to learn that this is the plane where they go. So when we do a prostatectomy, peripheral zone is left behind and the plane of dissection is pseudocapsule. When we talk about the prostate capsule, this is a separate. Prostate capsule is the capsule which is not a true capsule, also a condensation of the fibromuscular tissue around it, but it also looks black. So lining outside the whole prostate is the prostate capsule, which is anatomically or pathologically is a pseudocapsule, but still we call it as prostate capsule when we are discussing about the periprostatic spread. So this is the prostate capsule which we talk about in those cells. Further down, you can still make out this is the peripheral zone, BPH. Now, other structures, let me just point out. So, this is the head of the femur. That's how you make out head of the femur. Just inside is what? The obturator foramen and then obturator muscle. So, these are obturator group of muscles. So, obviously, when we are looking for obturator group of lymph nodes, this is the area which we should be looking for. And just on the posterolateral aspect, where the branches of the inferior vesical artery and the prostatic artery travel along the side of the prostate, this is the area of the neurovascular bundle. So we cannot make out these because there is hardly any contrast given here. The blood is flowing, so there will be signal void. So you can make out, but this is the anatomical location of the neurovascular bundle. So the nerves are traveling, the cavernous nerve, the artery, and the venous channels are traveling here, so on both the sides. Further down, further down, you will start looking at the viru. Viru is just appearing here. My pointer is at the viru. Maybe it will be better visible in the next slide. But this is the peripheral zone at the apex, close to the apex. I would not say it's just the apex, and the femur head is almost plain. Obturator is seen, and you can see these are the levator and iron muscles which are traveling further back and it will wrap around the rectus. So once you start seeing these normal MRIs more frequently, and then you will gradually pick up abnormal. Like here, you see, this is the folded hand view, very well seen. And as Dr. Sopana was telling, that at the apex, almost whole of the prostate is made by peripheral gland. And if you target this area, the positive rates are very, very high. Now, as you can see, the around the apex, what will also be seen, the levator ani, which was seen in the previous section around the rectum. So this is rectum. You can see the anterior component of the levator ani, and this levator ani here will be a pseudo-urethralis because it will be wrapping around the urethra as well. Now, curate is seen here. So this is just marking the levator ani all around, wrapping around. So why is it important? Because if they say, for example, there is a wide tumor here, and the interface between the levator and the prostate is almost gone. So normally you don't see a gap here. When you do surgery, they separate out, but still you can see the density of the tissue is different. But if there is a clear tumor here, which is showing an abnormal bulge on one side and the other side seems to be normal, you can make out that there is a very high probability that it may be invading the levator ani. It doesn't make sense to operate those patients because the tumor is invading the levator ani, meaning thereby you will be leaving the tumor behind and the patient may become incontinent after the surgery. So you can take this information while selecting the patient, what kind of treatment should be offered and whether surgery should be offered or not. Similarly, big chunk of lymph nodes around the ocular internus, it means the disease is high risk, it has already spread out, and you will obviously find other tumor, other lymph nodes in the rest of the body. I remember one of the patients where patient had polio in childhood. Now he was around maybe 60, 65, the father of one of the doctor. And I could clearly make out that these polio affects the skeletal muscles. So I could make out his obturator on one side was almost replaced by fat. So just by knowing the MRI, I could make out the effect of polio on the pelvis. And of course, on that same side, although the polio is not usually, it will not affect the levator ani, but the levator ani on that side was also not that bulky compared to the other side. And in that situation, we told the patient that his chances of having incontinence is higher than usual, and he chose to take another treatment. So this is how MRI also helps us in better decision making. So further down, only the peripheral zone around the apex is visible. Viru is no longer visible. You can see the levator ani anteriorly has become more bulkier. It is now contributing to this sphincteric function as well. Further down, we will start looking at the bulb of the prostate and rest of the perineal muscle. So this is the coronal, the same patient. You can see the bladder. So this is T2-weighted image, no doubt, because you can clearly see bright urine in the bladder. And in coronal, if this, say for example, there's a big tumor, you can see an asymmetrical bulge on one side with altered signal intensity. You can easily make out. Similarly, if there's the asymmetric tumor on one side and infiltrating this area. So if the interface between the levator ani and the tumor on one side compared to the other side. So in imaging, it is very important. You can always compare with the other side. If the disease is not symmetrically involving, you can always have a comparison with the other side. And you can make out in those situations whether you feel a patient should undergo surgery or not, based upon the chances of involvement of the sphincteric complex. So this is what the obturator is. This is what the levator ani is. And the external sphincteric region is this. So levator ani, few of the fibers will invest into this, and around the urethra there will be the external sphincteric muscle like this. So having a knowledge about the normal MRI will help you in making out whether the tumor in this area is resectable or not resectable, and if you attempt a resection, what are the potential harms in doing it. I think time is a limitation. Maybe I can show you a few images.
Please go ahead, sir. You can continue for a few minutes.
All right. So here I have included some of the examples where MRI I will show you how MRI helps us in better decision making using this information. So the first scenario is a non-palpable cancer, non-normal DRE. So here, although these images, this is a contrast enhanced images, this is a diffusion weighted image, this is an ADC map, and this is conventional T2 weighted image. So although here we have done all the sequences, but as we discussed earlier, if we just get a non-contrast MRI, meaning thereby this and this sequence and this sequence. So these are part of the bioparametric. The top line is bioparametric MRI. These itself are sufficient enough to make the right diagnosis. Like here, this portion, the bright peripheral zone, is normal. The tumor is here, a T2 hypointense. Hypointense means darker. T2 hypotensive intense ill-defined area anteriorly, which is not normally seen like this, raises the suspicion that there may be tumor. How we confirm? Diffusion weighted image. In a diffusion weighted image, anything abnormal like cancer will look brighter because of the restricted diffusion of water. If the restricted diffusion of water is there, it will look brighter. Now this is ADC map. ADC map is a calculation done from the sequences taken in diffusion weighted image. ADC is apparent diffusion coefficient. It's a calculated figure. But with this calculated figure, abnormal areas are seen. The corresponding abnormal areas mean the same area on T2 weighted image, which is abnormal. Corresponding area shows a restricted diffusion, and the corresponding area shows darker on ADC map, leaving no doubt that this is a some of the radiologists may label it as Pirate 4, other more confident and maybe extra confident one may label it as Pirate 5, saying that essentially a radiologist is telling you that what's about Pirate 5. Now with this MRI, obviously, if you do a DRE, it will be low suspicion. If say for example, this patient has a PSA of maybe 5.6, many of us may say that PSA is not very high, DRE is normal, benign looking, and if he is young, you may tell him go home. But if you do an MRI, you may find this picture. It doesn't mean that you do MRI in all the cases, but I'm saying if your level of suspicion is high, the PSA is showing a rising trend, doing a non-contrast MRI may add much more information. Another benefit of this MRI is that this disease is not palpable, not seen. But if you have an MRI, and then you will be doing a much better biopsy in him, because when you do a biopsy in this patient without an MRI knowledge, without knowing where the tumor is, you will be not hitting this area, because anterior to the urethra, we hardly hit this area if you don't know it. If, for example, Dr. Sood knows about it, if Sopan Sood knows about it, what he is going to do, he is going to put his needle here and then fire the needle, and he will be definitely picking it up. So anything, any person, any urologist who is confident, who is looking at the images, doing the biopsies themselves, will definitely do a better biopsy with this knowledge of MRI in this particular patient. Another example. So here is a 65-year-old. He had a serial rising PSA over 3 years. So he himself was a doctor. He was doing a PSA regularly. PSA was rising regularly over 3 years, but his rectal examination was normal. He was advised an MRI he didn't undergo. What he otherwise underwent was a TURP, because some of his urologist friend or maybe a surgeon friend in his hometown told that, why don't we do a TURP and we will have the biopsy? And you know what? He underwent a TURP, it was benign, but the PSA was still rising, and then he comes back. We got a plain MRI, and what we saw here is, so what we saw is the tumor is sitting all anterior. And obviously, this was missed while doing a TURP. You can see the TURP channel here. The TURP was done. The tumor is sitting anteriorly on the axial scan, all anterior. Normal peripheral zone on this side. Here, peripheral zone is partly, I would say, not exactly normal, but we may need more images here to say that it is abnormal. But you can see on a diffusion weighted image on the ADC map, this is the ADC map. On the ADC map, it's a darker area. So MRI showed a Pirate 4 lesion. MR cognitive biopsy. Why cognitive biopsy? No, why not a fusion biopsy? Because we were sure that looking at MRI, if we take the right step, we can still pick it up. So without doing a fusion biopsy, the biopsy was done right and it came out to be suggestive of tumor, and then he underwent radical prostatectomy later on. Another example, 66-year-old Kenyan from Kenya, he came for a checkup. His PSA was high. We asked about him that he said that yes, in his home country, PSA was also high earlier, but still not very high. I would say 6.4, many of us may just sit on it. Rectal examination absolutely normal, and we can see on the MRI, it would be normal because the peripheral zone seems to be fine. Now, on a T2 weighted image here, there was the suspected lesion. So let me come first to the restricted diffusion. So this is the diffusion weighted image, which showed a brighter spot, means highly suspicious area at the left side base of the prostate. Now the same area was not very well seen. I would say it was not very well appreciated on a T2 weighted image because closer to the bladder neck, where the central gland is there, sometimes it is difficult. Why I'm saying it's closer to the bladder neck and near the close to the central gland, because we can see the seminal vesicle. So the part of the ejaculatory duct will be here. This is the area of the central gland. His prostate was not very big. So we are not able to appreciate much on the T2 weighted image, but more important, in the peripheral zone, we read that restricted the diffusion weighted image should be given more importance. So you can see clearly a restricted diffusion on a diffusion weighted image and a darker corresponding dark area on the ADC map. Although it was not very well seen on T2 weighted image, but based upon this information, if you target this area with multiple biopsies, or maybe you can do an MR fusion biopsy in this particular circumstance, then your chances of picking up the cancer will be very, very high. And this is what happened in this patient. So biopsy was done, fusion biopsy was done in this patient, although some experts can also do a MR cognitive biopsy and get the equally good results, because the roadmap is there. You know where the tumor is. So this is what I was just discussing a little while ago, that if you know the tumor, especially the anterior tumor, your biopsy pickup yield will be much higher. The reason I've shown here is that when you do a normal biopsy, you reach to the prostatic capsule and then throw. And the throw of the needle is limited. It's 20 mm. If the tumor is beyond the throw of the needle, and if you have not gone inside the prostate, which we normally do not do, why we do not do? Because peripheral zone is the most common area, and the anterior fibromuscular stroma has only 5% of the cancers. But if you want to pick up these cancers, we need to know the road map. It's like going around in a jungle without a map. So if you have a map, you will probably make the right decision. So in conventional biopsy, your needle will be here, and what you do is you fire and you miss it. But if you already know it, then you will go further inside the prostate and then you will fire. Now, MRI for missed cancer on previous biopsy. I will show you another example where you will see why it was missed. Now, this gentleman has undergone, he's a 65-year-old, he has undergone 2 biopsies previously. So this is the actual OPD note from March 2018 when he came to us. And he had already undergone biopsy in December 17 and then January 2018. 2 biopsies, no tumor seen. He had a normal DRE. Only catch was ultrasound showed a big prostate, 113 grams. So this is what we put down on the examination finding. What was actually happening is that no palpable lesion, but we could not reach the upper extent of the prostate. So upper extent of the prostate could not be felt. It doesn't mean it is a normal DRE. It simply means this is inadequate DRE. I could not feel the upper half of the prostate because of the body habitus and big prostate. And what happened was exactly the reason why 2 biopsies missed it. So this is the mid gland, normal peripheral zone, same patient. We got the MRI done in December 2017. So this is the MRI which was done, but unfortunately the person who did the biopsy didn't look at it. So even though MRI was done for the sake of doing it, but if we do not see it, The radiologist was not able to, I'm not sure whether he was able to give this message or not, but the urologist is supposed to say, mid gland is normal, up to mid gland everything is fine. The only area which is abnormal is the right seminal vesicle. You can see the altered signal here in the seminal vesicle. Probably actually it shows a normal bright signal on T2 weighted image. Why? Because seminal vesicle liquid is there, but the seminal vesicle was involved, and this is the only abnormal area in a 113 cc gland with a normal DI. That is the reason why it was missed twice. So you see this sagittal, the only abnormal area is the base of the prostate and up to the mid of the seminal vesicle with the type 1 invasion, meaning thereby the tumor going in the seminal vesicle only. Rest of prostate, such a big prostate, absolutely normal. And when we did DRE, we could hardly feel this. We couldn't even feel this area. Now, just because he had a previous negative biopsy, is big prostate, and as you can mention, we are doing MRI in most of the patients. So you can see even a plain MRI. So here there is no contrast image. It's a plain MRI. Even weighted image helps only in finding out whether there is a...
Ajay sir,
yeah.
You're showing us really beautiful images, but
okay, so we'll wrap up. So I will finish with this case and then we'll go.
Yes.
Tumor at the base, and then this is the I will leave. This is the just the running image, so I will not. And this is the biopsy report of this gentleman. All the pores are negative except right base and the seminal vesicle on the left side as well. I think there may be an error in labeling it, but right base and the right seminal vesicle, or maybe adjacent seminal vesicle was also involved. But what I'm trying to tell is the only tumor which was there at the base was there and it was missed, and that's how MRI may help. So I'm sorry I could not spend more time on the rest of the case, but maybe we will find some other time and we can discuss all these things in greater detail. But at this point of time, what I would urge all the practicing urologists is that start learning MRI. It's not difficult at all. Start with the normal, start with basics, and gradually you will become. Thank you.
Thank you, sir. You always